See, I forgot I was taking that off. I'm ready. Good afternoon and welcome to the weekly update from the Department of Behavioral Health in Fresno County. I hope all is well with you. We'll jump right in. All right, it remains Women's History Month, and this month we have a couple of events in celebration of that. We have two panel discussions focusing on women in behavioral health. The first one is Friday, March 19th. That's a week from tomorrow from 12 to 1:30 p.m., focusing on wellness and holistic health throughout her story. And then on Friday, March 26th, the following week, intersectional healing throughout her story. Little play on history with her story. And we have some nice panelists on each, and those will be streamed on Facebook Live, I believe. And so tune in. All right, March is also Social Worker Month, and we know that social workers are essential, as are all of our staff, all of our partners. All right, COVID in the world. We now have over 118 million cases of COVID worldwide, and we've had over 2.6 million deaths worldwide. In the United States, we've now passed 29 million cases and 530,000 deaths. In California, we are close to 3.5 million cases, and we have over 53,000 deaths. We've also administered almost 50 million tests. That is more than one for every person who lives in California. And we've now administered over 9.6 million vaccines, which is really good news. It's actually a little more than that. This says March 4th. I didn't update it. My bad. But what I do want to note, because this is updated, is that our overall positive is 2.4% in the last 7 days, and that is a slight increase from last week. So it's tiny, from 2.1 to 2.4, but it is notable, and so that's something we'll be watching very closely. In Fresno County, we have 96,866 cases and 1,519 deaths. And in terms of hospitalizations, we have 152 individuals hospitalized. 34 of those are in the ICU, leaving 15 ICU beds. Of note, that represents a decline in hospitalizations over the last several weeks, as you can note from the figures on the right side. However, we did have a little blip between yesterday and today of about 10 patients. So again, just something we're watching closely. Nothing of concern, but we just need to watch it very closely. And if you look at our tier, we are still in the purple tier, and we've continued to decline in positivity, but we still have more than 7 cases per 100,000 per day. And so that averages out to 12.6 per 100,000. And we need to get under 7 to get into the red. Remember, once we get under 7, we have to be there for 2 weeks to get out of the purple tier and into the red tier. In terms of the vaccine dashboard, as you can see, there's actually been almost 11 million vaccines administered across California, 221,654 in Fresno County, which is just great news. Remember that this next slide is a little out of date with the one I just showed you. So this one shows 213,000 vaccines. We've administered over 12,308 in the week prior to Monday. And we have 80,941 of the residents in Fresno County partially vaccinated, and now over 56,000 fully vaccinated. So that's really good news. Across California, though, however, if you look at this next slide, HPI is referencing health equity, essentially. And so we're looking at the census tracts with the lowest and highest socioeconomic classes. So on the left-hand side is the lowest, and then on the right-hand side is the highest. And so we are vaccinating more people with more healthy community conditions. That's why the governor has decided and determined that we're going to put more of the vaccine, 40%, to underserved communities, because we need to get those vaccinations up, because those are the individuals who are likely to have a worse time with COVID. So we really need to focus on that population. All right. Johnson & Johnson started arriving this week in Fresno County. And of note, a few things. One, the next tier opens up next Monday. And that is for individuals who are 18 to 64 with underlying health conditions. That includes the people we serve, both in the behavioral health, mental health, and substance use disorder. We do plan to have a closed clinic, much like we did when we vaccinated staff. But individuals who are served in our system of care, or if you have loved ones who fit this tier's criteria, can get vaccinated at any open clinic. And so we'll have details forthcoming in the next several days about those clinics and how the people we serve can access them. When we talk about having a closed clinic, that means a clinic just for the population we serve. I'm certain I'll get questions about your loved ones or friends coming to our clinic, and there will be lots of other clinics open in the coming weeks with our additional vaccine doses we're getting, where you'll be able to get vaccinated. It's really important. There's almost every grocery store that has a pharmacy, every drugstore that has a pharmacy now has vaccine doses. It's a little harder because most of them aren't on the My Turn app, and that's My Turn is the way the state is moving towards for people to register to get vaccinated. And most of those pharmacies, you have to go on their individual store websites. And so that's another way to access vaccines. But again, we'll have more details forthcoming. So I keep getting asked questions about the vaccines. What about fertility? What about, can I still get COVID? Can I spread COVID? And will this protect me from variants? I'm hearing the variants, we're not getting as much protection. So I thought I would talk a little bit about why we don't know more at this point. And so scientific research has a structure. I'm going to do real high level, so if you're a scientist and you feel like I didn't touch on the important points, feel free to let me know, but mostly I'm just trying to give you a feel. So when you're doing research, you're developing a hypothesis. So will this vaccine be effective against COVID is the hypothesis for the vaccine research. Will it prevent COVID? Will it prevent illness from COVID? Will it prevent death from COVID? Will it cause any unacceptable side effects? How will it impact people with underlying health conditions? What long-term impacts might it have? Are all things that can be studied by looking at these vaccines. But generally what a study does is it has a control group and what we call a research or a study group. And the control group has no intervention, although I'll describe that a little differently in a minute, and the research group has the intervention. So in a vaccine study, whether you're in the control group or the research group, you will get a shot, because that's one of the things you want to keep homogeneous when you're doing research, is that each person getting the shot doesn't know, did they get a placebo or did they get the vaccine? But the control group doesn't get the vaccine. The research or study group does get the vaccine. What you want when you're designing that study, you want those two groups to look alike as much as possible and to look like the general population. So one of the complaints about research in healthcare in the United States, in the history of the United States, is most research for medications and interventions for health conditions has been done on white males. And so a lot of times we don't know as much about the impact on women or the impact on people of color because that research didn't consider that we might have different responses to medication. And so with the vaccine research, there was a concerted effort to ensure that as they got study participants, people who signed up to say, yeah, I want to be in this study, maybe or maybe not get the vaccine, and help inform whether or not the vaccines work. And so you want the general population to be represented in that study group. You want, if the general population is 50-50 men, women, you want 50-50 men, women. If the general population has a 40% Hispanic or Latino, you want your study population to have that, etc. And so as much as possible, you want the demographics to be reflecting the general population, and the same in the control and study groups. You want them to look a lot alike and look like the general population. Then once you have enough of each of them, you need to have enough participants to draw a conclusion. If the research on the vaccines was done on 25 people, it would be impossible to draw conclusions because they couldn't possibly represent, it's not statistically significant, and they wouldn't represent the general population. So that's where you see thousands of study participants in these vaccine research studies. You can't measure too many variables at once. That's why we don't have a vaccine for kids yet, because they were just looking at adults first. That's very typical for a couple of reasons. One, you again need to have enough of those participants and represent the general population. But typically in research, we want to test it on adults first, right? Before we test it on kids. And then it's also why we don't have as much information on pregnancy. The study didn't ask for pregnant women or exclude pregnant women. It did look at whether or not women got pregnant during the study. And obviously, if someone was pregnant and they didn't want to participate, they just didn't sign up to be a study participant. And then for vaccine research, or really a lot of medical research, you need enough time to pass from the time of the intervention that the effects of that intervention can be determined to a high degree of certainty. So again, you have to have statistically significant information. And so with the vaccine, and I talked about this briefly in a past presentation, but with the vaccine, you needed enough people, particularly in the control group, to get COVID, to be able to definitively say that more people in the control group who didn't get the vaccine got COVID than people in the study group that did get the vaccine. You can't do that after a week or two, probably not even a month or two, but you need that to happen. You need time to pass, people to be going about their daily lives. That's how this research worked in the vaccines. They didn't put people in a bubble somewhere. That would have been too many variables. They didn't ask people in one group, like the research group, to stand on their head 5 times a day, because that would have been too many variables. They just gave them a shot. You either did or didn't get the vaccine, and then they watched you. Did you get symptoms of COVID? If people got tested for COVID, or if they had gotten hospitalized or that type of thing, they tracked those people over time until they could determine enough people in the control group got COVID to really definitively say that people who got the vaccine were not getting COVID to the same degree. And so that effectiveness was, 94% of the people who got the Pfizer vaccine did not get COVID or have symptoms of COVID. But because time has to pass, that's why we don't really have, we don't know with certainty about any impact on fertility. We do know, based on the mechanism of the vaccines, and I've talked about this in past presentations, I'll just briefly talk about it here. The messenger RNA comes into the cell. It doesn't enter the nucleus of the cell and affect your DNA. It just tells your cell to make this spike protein. Your cell makes the spike protein. Your body recognizes it as foreign, and it develops an immune response and antibodies, and that's next time the spike protein comes in the shape of COVID, it fights it off, right? But none of that gets into your DNA. It doesn't change your genetic makeup. And that is typically what you might expect to happen if there were going to be an impact on fertility. So in terms of what we know about fertility, what we know about viruses, what we know about vaccines, there's no reason to believe that there will be an impact on fertility. But enough time hasn't passed to say that with certainty. The other thing is, thus far, there's nothing we've seen with people who've had COVID to understand that it has an impact on fertility. But again, enough time has to pass for us to see if perhaps that is the case. And then this time passing is why we recommend that you still follow the precautions, because we don't know if you could still get COVID and not have symptoms and pass it on. We also don't know that you do get COVID and not have symptoms and pass it on. But that's something we're going to tell over time. And I think I've mentioned this before too. Some of us signed up for that V-Safe through the CDC after we got our vaccine, and I've been reporting out every week, and it asks me questions every once in a while about getting pregnant or the possibility of getting pregnant, and that's how they'll begin to gather information from all of us ultimately who get the vaccine to understand, is there an impact on fertility? So the other thing to mention about fertility is that there were women who got pregnant during the vaccine research studies in both the control and the study group. Of note, it was not that many women. I'm guessing because a lot of women who thought they might get pregnant just didn't participate. They might have been too concerned about that. But some women did get pregnant. And thus far, with very, very small numbers, there's no evidence that there was a higher incidence of miscarriage or impact on the pregnancy that way. And then, of course, we don't know yet about any impact on the baby. But so far, we're not seeing babies being born with birth defects and that type of thing. And so this is something we'll be watching as we go along. And we will eventually know the answers to these questions. It's just that enough time has to pass where enough of us get the vaccine and have the vaccine for a long enough period of time to really understand the impact. It's not poor science, it's not that they didn't do a good job or didn't cover all the bases. This is the nature of research and the nature of studies and just what we have to tolerate in order to learn about the impact of these. So hopefully that helps you a little bit to understand that. What we do know is that herd immunity is building. And herd immunity isn't an on-off switch. It's not like we have no benefit from vaccinations until we get to 70 or 80% vaccinated or having had COVID. Slowly but surely, we should begin to see an impact in terms of a decline in case rates. And we are beginning to see that. One scientist believes that about 30% or as many as 30% of the public have had the virus. Obviously, that's higher than the people that have had tests and shown they had the virus, but that's because we think that there's still a lot of asymptomatic virus where people never know they had the virus. And as many as 18% have been vaccinated. So some researchers are saying as many as 40% of the population, because there's some overlap between people who've had COVID and went ahead and got vaccinated, that maybe we're at 40% herd immunity. So we're well on the way to getting there, hopefully. We are continuing to see cases slowly decline as well nationwide. It'll be interesting as states open up, as we know they're starting to see if that continues to play out as those precautions aren't being followed to the same degree across the United States. But thus far, although we've seen some blips, there's not significant trends in the opposite direction. So those case rates, hospitalization rates, deaths are all declining. And vaccinations are rising as Johnson & Johnson came on board. And as we get more and more vaccines from the manufacturers, that 18% will go up. And then the variants are looking a little less scary right now. And that's based on in Brazil and South Africa, where for sure the variants from those places have taken hold. And what I mean by that is when people test positive for COVID, they're testing for the genetics of the virus and they're confirming that those known variants are the most predominant representation in the cases. And yet we're not seeing cases go up significantly in those locations. And so we're still learning about whether or not those variants result in more sickness, but we're not seeing the rise in cases that you might expect if the variants were significantly more infectious. That could change, we'll keep watching, but some signs that those variants may be not as dangerous as we had thought. Definitely, and I think someone pointed this out last week, anytime a variant has a mutation that allows it to join with the host easier, it will slowly but surely become the prevalent variant of the virus in an area. What we watch is, do we see those case rates going up? Do we see that positivity going up? And that would tell us that that variation has a worse outcome for us who get the virus. All right. And with that, we'll just say that haven't really heard anything new on telework continuing, but that also means we haven't really heard that it's not continuing. And as I've reported out for several weeks now, we'll continue telework until that is lifted and we have the right measures in place to have a comfort level that we can safely bring both the people we serve and our staff back. So we'll be watching that tier we're in. We're still in the purple tier. We'll be looking at volumes and variant activity as well as vaccinations, because in our area, we're a little lower in percentage than in some parts, and so we need to keep increasing. I think I reported on this last week. We're now getting about 35 to 40,000 doses of vaccines each week. And that's significantly more than what we were getting in the beginning, which was more like 7,000 or 8,000. And so we really should begin to see that pace increase and more people get fully vaccinated. With the introduction of Johnson & Johnson, remember it's one shot, so right now it's like a 3 to 4 week time between partially to fully, but when you get the Johnson & Johnson, boom, you're fully vaccinated 2 weeks after you get the shot, so that's great. Still highly encouraging testing. It is a variable the state looks at, and a gentle reminder that if we don't test, we don't know how bad it is. We've got to know how bad it is to make good decisions. So continuing to get tested, particularly if you have symptoms, is super important, both to prevent the spread of COVID by taking the precautions you need to take if you're positive for COVID, but also helping inform us about the prevalence of COVID in our community. And so wear your mask, physically distance, do all those things. I'll look for questions. I don't see any questions right now. I keep getting to this point and not having as many questions, and I think, oh my goodness, people have run out of things to ask me, or maybe we're doing a good job with answering questions. I'll give it another minute or two. I also always check my text because Tina sometimes gets text messages or emails from some of you who aren't either able to ask in the chat or would prefer to do it separately. I'll also remind you that if you watch this later or you're watching a recording and you weren't able to ask a question and you have one, please send it to Tina or myself. I think we're pretty good about getting back to you via either text or chat, or text or email, however you send us the question, and we'll also bring it up here if we think it's relevant for everyone. I keep hearing this pandemic is not the big one. What will the big one be like? Well, the big one, if there is a big one, will probably be like some of the movies we've seen. And what I mean by that, I think I've talked about this before. So there's viruses like Ebola. Ebola has a really high fatality rate, but Ebola is less likely to be the big one, mostly because once you are exposed to it, you develop the symptoms fairly quickly, and you're only contagious while you have symptoms. And your symptoms are pretty graphic. People are bleeding from their orifices. You're really, really sick when you have Ebola. And so the chance that you're going to get on a plane or be out and about in the public spreading it without people knowing that they're getting exposed to Ebola is pretty low. So if you took something like COVID that spread very, very rapidly across the world, had maybe a little longer incubation period, so instead of that 7 to 10 or 14 days between the time you get exposed to the time you develop it, if that time was longer and you were infectious for a longer period of time of that time, that could be bad, right? Because even more people could be exposed before you ever even knew that you had it. And then if the virus, once it takes hold, does worse things to you than COVID, so you have this period of time that's longer where you're infectious, where you don't know it, where you can get on a plane and travel and go somewhere and go out to eat and go to church and do all those things and potentially expose people to a virus that you don't even know you have. And then when you develop it, it has a high fatality rate. That would be the big one. That we would have this prevalent virus that we didn't even know was going to hit us because there's a long lag time. And then when people get sick, it's really, really fatal, a high percentage. So SARS and MERS were a little bit like that, where they had a much higher fatality rate. But it's a delicate balance with a virus, because if you're a virus and you kill all your host, you don't spread as much. And so you kind of die out, because if people get it and get sick pretty quickly and then die, they're not spreading it to other people, and the virus eventually doesn't have a host. I read this interesting article about, are viruses alive or not? Because viruses can only live if they're in a host. And so are they alive or not? It's an interesting conundrum. But they need that. They need a host, an animal host, a human host. They can't reproduce themselves on their own. They have to get in your cell and have your cells reproduce them. And so that's the kind of big one it would be, is you're spreading it without knowing it. That's what's scary about COVID, is you can spread it without even knowing you have it. And then whatever the virus causes in your body, you have a higher fatality rate, and there's no treatments for it. And so that would be the big one, something that spreads and is more fatal than what COVID was. With new CDC guidelines saying that fully vaccinated people do not have to be masked around one another, will mask guidelines change in office? That is a great question. I think in one of my slides, and I had under the scientific research structure, slide 18, Brian, under time passing, I said this is why we mostly still recommend precautions. The CDC did come out this week with guidance saying if 2 people have been fully vaccinated, or several people have all been fully vaccinated, they can be around each other without masks. It is possible that our guidance will change moving forward, but I don't think that's a focus right now of the Department of Public Health, and if it changes, they'll let us know. Of note, that CDC guidance doesn't apply to hospital settings, where it's much more likely that people sick with COVID are. And so we are waiting to hear about that, any updates to the guidance in hospital settings, like if a nurse or a doctor has been vaccinated, do they still have to have that N95 mask on? I'm guessing they'll want it on, but that's the kind of guidance that could change for sure. For non-clinical staff, do we sign up for the vaccination as a healthcare worker? What proof do we provide? Our badge? Yes. Yes. Any updates on possible long-term telework options? Asking for a friend. Sure you are. I don't have any sort of formal guidance in terms of telework. It's something we're talking about internally, and we'll be looking at. And here's the types of things we'll be looking at. We have some jobs for whom you have to be in person to do the job. If you have a job like that and you're not in person, we probably gave you a different job to do, or we're struggling to give you jobs to do. So that job is going to come back to work. If you have a job that can be done remotely, we'll be looking at, is it a job that we can measure your effectiveness at doing the job, or anyone's effectiveness at doing the job? Is there productivity, and I hate to say productivity standards because that always scares everyone, but if you have assignments, are they getting done? If you have work, is there a way to tell that you're doing your work? Is there a way to check and make sure that you're effective at home doing that job, not being in a work setting? And then there may be some positions that we say some of them could be at home, or we'll have to, we could divvy up the work and say some could be remote and some not. I do anticipate that there will be some positions for whom telework might be an option. I just can't tell you with certainty what those positions are and what that's going to look like, but please know that we will be looking at all of those things. Any updates on traveling outside of the country? The government is still looking at that. I think that, we're bound by a couple of things. One, the country you travel to might have restrictions, might have requirements either that you have a negative test result prior to coming there, after you get there. There's quarantines in many locations, and similar in some states in the United States. I know that Hawaii right now requires you to take a test within 72 hours of departure. And it has to be, you have to get the test results back within that 72 hours, and it has to be negative. It has to be uploaded to the Hawaii website, and you have to carry a copy with you, and then you're not subject to a 14-day quarantine. If you don't have that, then you're subject to a 14-day quarantine, but you can't even get on the plane if you don't have that and you don't live there. I don't even think you can get on the plane if you don't have that, so the 14-day quarantine seems silly. But if somehow you got there and you didn't have all the requisite paperwork, you're in quarantine. And so it's a little variable right now. I do anticipate, again, as time passes, as we know more and more, just like the CDC guidance updated in terms of mask wearing, I do anticipate that in the United States, we'll make some updates in terms of quarantine and travel, but we don't control what happens in the rest of the world, so that's something we'll have to watch closely. Not all employees are getting the vaccine, so I would think that a mask would still be required. Right now, the CDC guidance is that if you both have been vaccinated, you don't have to wear a mask. But if you're with someone who's vaccinated and you're not, you both wear a mask. So that's absolutely correct. And so, I don't know if we'll wear a badge that says we've been vaccinated or if we'll just continue with masking because we don't want to deal with that. That's why we haven't changed the guidance yet, and we're still wearing masks in the office. Is the county going to survey the person served to see if they prefer telehealth? Yes, we will be doing some research of our own. This won't really be scientific research, it'll be a survey. But we will be looking at how effective is telephone and telehealth for our population that we serve. And we will need to do that study in such a way that we do understand those demographic variables and we understand what works and what doesn't work. So the types of variables that we will look at are, does the person lack the proper equipment in order to engage in telehealth, the video? Do they lack a private space in order to feel comfortable engaging in telehealth or video? Do they feel that it benefits them, and are they achieving their recovery goals through telehealth? Those are all things. Other things we're looking at are certain age groups that might, it's very difficult to do telehealth with very young kids, that type of thing. And so all of those things will be looked at, and certainly the person we serve's preference will be part of what we'll be looking at. I don't see any other questions there. Let's see if we have some here. Nope, no questions there. All right. If no more questions come in, then that's the end of my update. Have a great weekend, and I will see you next week.